Pleasure to be here. I'm John Redd. I'm the ASPR Chief Medical Officer, and I've had the privilege of supervising the HHS ASPR efforts on allocating, distributing, and facilitating administration of initially remdesivir, but now most recently the monoclonal antibodies for the treatment of COVID-19 in outpatients. And wanted to give a quick welcome to everyone here. We're very, very thankful to Project Echo and the team for hosting this informative sessions. And I wanted to say, just to open things up, that we're enthusiastic about these products because if you look at the continuum of care for patients with COVID-19, these antibodies fit into a portion of care for which at the current time, we actually, unfortunately, have had very little to offer until these therapeutics came out under emergency use authorization. So these products are intended for use in outpatients who are early in their course and who have risk factors for progression to hospitalization. So we're excited to hear from our panel. We're excited to hear about the use of these products in expanded persons. And it's a pleasure to be here, and I'll turn it over to Dr. Wong. Thank you very much. Welcome.
I'm going to hand it over to Bruce for logistics.
Great. Thank you, John, and thank you, David. I'm Dr. Bruce Streminger. I'm professor of medicine at the University of New Mexico, and it's really our pleasure to be supporting this mini-series on outpatient therapeutics for COVID-19, along with HHS ASPR. Just going to go over a few logistic items and to help us get going. We've got a Q&A feature at the bottom right. We really appreciate your questions and your comments. So please put them there, and we'll be monitoring that throughout the session. And we will try to get to as many of your questions as we can. If you have any technical or logistic issues, please put those in the chat feature. We are recording this session, and your attendance is consent to be recorded. Thank you for that. The presentations are linked. Today's presentations from our presenters are linked to the email that went out this morning. We will also be sharing those on a website associated with this series that we'll be putting up in the next couple of days, along with a link to the recording of today's session. We will be offering CME and continuing professional development credits through the University of New Mexico, where Project Echo is based. We'll share a link to a short anonymous survey that will lead up to your getting instant CME and CPD. You will also have up to 48 hours to complete that. We really appreciate your feedback, and as we're developing and designing this mini-series on outpatient therapeutics, we'll really take into account what you share with us about what you want to learn about over the next month and a half or so. These learning sessions are focused on improving patient care and health systems and supporting clinicians. Just a reminder to keep them apolitical and non-commercial. Thank you for that. A word about data. When you registered, when you put questions in the chat and Q&A, you're sharing data with us. We just want to ensure everyone, we take data stewardship very seriously, and what data is identified, we de-identify before we share that with HHS ASPR. Very briefly, want to go over today's agenda. We will start out with an overview by Janet Woodcock, who is the lead for therapeutics of Operation Warp Speed, and also the longstanding director of the FDA Center for Drug Evaluation and Research. She'll give us an overview of the data related to the clinical trials related to these monoclonal antibodies. We'll then have 5 minutes of Q&A. We received your questions up front. We'll be using some of those, but please also share questions real time, and we'll try to get to as many as we can. We'll then go to a case study from rural Kentucky about the implementation of bamlanivimab there, and be joined by colleagues from Ephraim McDowell Health. My colleague, Dr. Christian Ramers, who is with Family Health Centers of San Diego, will be co-facilitating the session with me, and he'll be facilitating that portion, as well as we will be moving on to, we hope, about 30 minutes of the session today will be a discussion with a series, a great group of expert panelists representing a wide variety of practice settings and professions. So with that, I'm going to stop sharing my screen, and it's really my pleasure to welcome Dr. Janet Woodcock. As I said, she is the lead for Therapeutics for Operation Warp Speed and is the director of the FDA Center for Drug Development and Research. So Janet, we're looking forward to your talk.
Thank you, and hello everyone. I'm really delighted to be able to talk to people and actually hear what the issues are out there. I'm going to talk about the clinical data that was generated on these monoclonal antibodies, and also a little bit of questions about what about vaccination after being exposed to these therapeutics. Kind of the next slide. So people might wonder, the virus was only sequenced in early winter last year, and now we have specific monoclonal antibodies. That's really because the platforms for generating these have matured over many decades, and these are companies were able to generate specific neutralizing antibodies against the virus and crash onto development programs, get into the clinic. But this isn't the kind of data, say, that you might used to be seeing for a drug development program because of the emergency. So FDA has granted 2 emergency use authorizations for monoclonal antibodies to treat high-risk outpatients with symptomatic COVID-19. And one of them is from Eli Lilly, the bamlanivimab you've been talking about, 700 milligram dose, and another is a cocktail from Regeneron, 2 antibodies against different epitopes that are 1.2 grams each. And the conditions of use, I think the FDA made a big effort to make sure that they're very similar, so there will not be a lot of mix-ups. They require an hour infusion plus 1 hour monitoring post-infusion. And the safety data, actually, I'm not going to go over because it's very similar for both. Low risk of infusion reactions, including anaphylaxis. And this was more common in the higher doses that were used in the trials, but not very common in the doses that are being used in emergency use authorization. And the emergency use authorizations, very importantly, do not include hospitalized patients. And I'll talk about that in a minute. And I see somebody's asked about conflict of interest. So why don't I declare I have no conflict of interest, except I do work for Operation Warp Speed, and our issue is to get treatments to the American public. Next slide, please. So again, I think the FDA worked with the companies to try to get a target population that is identical under each emergency use authorization. These are people who are at higher risk for hospitalization, because much of the whole purpose of this program is to prevent hospitalizations, although also it appears that it will shorten symptoms of symptomatic people who remain outpatients. Next slide. So let me go over the development program that Lilly put forth. I think this is confusing to people. So Lilly actually has 2 neutralizing antibodies. Bamlanivimab is the only one that's being used right now. It has a very potent neutralization at the receptor binding domain of the spike protein. And so it interferes with the virus in getting into the cell. They also have another antibody, but it's coming later. And so it wasn't into the clinic as quickly, and we don't have a lot of data on the combination. generally, these combinations would be used together to prevent emergence of resistance during treatment. Now, as far as the efficacy trials that were done, BLAZE-1 was a Lilly-sponsored platform trial that had a bunch of arms in mild to moderate outpatients and a dose comparison versus placebo. And this is a virologic study, and they picked day 11 for their viral load comparison. This turned out to be the wrong day, but and you'll see in a minute with the virus data. And then they were able to add arms because it was a platform trial using the combination versus placebo. And in both of these studies, arms, they looked at duration of symptoms, shortening duration of symptoms. But they also did doing a post-exposure prophylaxis study in nursing homes. We expect that may read out fairly soon. And our platform trial sponsored by Operation Warp Speed at NIAID also had an outpatient and an inpatient study of this antibody, the bamlanivimab. And what we found, the inpatient study was terminated for futility. So this is why it's not recommended to use these antibodies this antibody in patients right now. Next. So what they did was do an interim analysis from this platform trial that occurred after people had gotten through day 29 of the trial. As I said, it was an RCT with people with symptomatic COVID who were within 3 days of having a positive PCR test or positive test for the virus. And they were given a single infusion of a bunch of doses. Next slide. Now, this is a pre-specified primary endpoint, and this is a log scale on the left. And so what you see is that all 3 doses, they seem to be above the top of the exposure response curve with all 3 doses. All 3 of them dropped the virus more quickly. But then when you get down here, the primary endpoint at day 11, most people, this is like 4 logs less or 3 to 4 logs less. So they had basically cleared the virus at this time, most of the people. And so it wasn't a good time to do the comparison. Next slide. The secondary endpoint was really COVID-related hospitalizations or emergency room visits within 28 days after treatment. And what they saw was this for each one of the doses. The baseline rate in the enrolled population in the placebo was 6%. And for each of the doses, it was reduced significantly, and not statistically significantly, but numerically significantly. You could see this was very few events because a very high-risk population for hospitalization was not targeted. And if you look at all the doses, you get down to about 6 versus 2% hospitalization. Next one. But if you look at people at the EUA criteria that we're using, okay, that are currently being used, the ones I showed in the beginning, the higher risk, they had a hospitalization rate of 10%. And if you look at all the doses, it was 3%. The 700 milligram had a 2% hospitalization rate. Next one. So then there was a combination arm, as I said, that looked at this, looked at the combination and looked at the same type of endpoints and same population, enrolling mild to moderate patients with the viral load outcome. Next slide. The combination therapy did reach statistical significance at day 11, as you see, and at day 3 and 7, again, there was quite a reduction in viral load compared to the placebo. And they looked at people with persistently high viral load. They looked at this with a single antibody and a combo, and it showed that there was, the people in general are heading to the hospital, some of them, were the people who weren't clearing the virus rapidly. And so they found a big difference that in those people with high placebo with high viral load was much lower in the treatment arm. Next one. All right, so this trial, for this virology trial, met its pre-specified endpoints, and improvement in symptoms with the combination. And they also saw an improvement in symptoms with the single as early as 3 days after dosing. But also as a, not formal analysis, the rate of COVID-related hospitalizations and ER visits was lower. It was 0.9% versus 5.8% in the placebo arm. This is for the combination again. Next one. Now, Regeneron actually, they also did a virologic trial with their combination. It was an RCT, placebo-controlled with 2 doses, as you see there. Primary endpoint viral load through day 7. They picked an earlier day, and therefore they got a highly significant p-value. They found, again, the greatest difference was in people who had high viral load to start with, and they also looked at whether they were making antibodies. And those people who were not making antibodies were the ones in whom this antibody being added made a difference, made very little difference in the people who are already making antibodies and clearing the virus. They had a predefined secondary endpoint of medically attended visits, which included telehealth and so forth, 6.5% in placebo versus 2.8. Then if you look at the EUA population, the high-risk population, you see that it's 9% in placebo versus 3%. So next slide. The bottom line, the EUA population that we're asking people to treat, the reduction in ER visit or hospitalization for the Lilly single antibody, they had a 10% hospitalization rate in that population versus 3%. When they looked at extremely high risk, which would be BMI greater than 35 or age greater than 65, they had a 14% hospitalization rate versus 4%. In Regeneron, 9% with the EUA population versus 3%. And I don't have access to primary data, but the Lilly combo product, which is not the EUA population, had a fairly low hospitalization rate, because this is not the high risk population, but versus 0.9% in the people who received the drug. Next slide. And finally, I'm trying to get through this quickly. Most infected patients are already mounting their own immune response at the time of antibody administration. That's what we found from these trials. So the question has been raised, the use of the vaccine after a monoclonal has been administered. So it is very likely that therapeutic use in people already infected and have been exposed to the virus is unlikely to cause concern, because they are already in the process, some of them very sluggish, but they are mounting their own immune response. But this issue will be studied as soon as the vaccines are available. We are collaborating with NIAID to set up these studies. Prophylactic use, though, in healthy people who have perhaps been exposed pre or post exposure, there are multiple studies underway with monoclonal antibodies. If prophylactic use is effective and begins to be used, that'll be more concerning with respect to vaccination. Some of the antibodies have long half-lives, well beyond the 21 days that is sort of normal for this class. And so we will also study administration of vaccine after prophylactic use, if in fact that would be approved for an EUA or approved and available in some other way. So I hope I didn't take too long, and I'm happy to answer questions. Thank you.
Janet, thank you for that terrific rapid overview, very comprehensive, and you did a great job on the timing. I've got a couple of quick questions. One is, when will the phase 3 data be available? Any sense of that?
I believe that data will trickle out over time on these antibodies. I think Lilly had pursued a trial of the combination because combinations really are desirable, right? Because of the escape variant issue, okay? In high-risk people similar to the EUA population, and we will see those data. We'll also see prophylactic data. We will see the data from Active 2, which closed its study after, I think, a couple hundred people because of the EUA being granted. But those data, they did extensive virologic studies. They did not target high-risk people, though. So probably the pivotal trial for this will be the combination product in the EUA type population. Regeneron is continuing to pursue placebo-controlled trials in their seamless phase 2-3 program. So we should get more data out of that as well. I think what happened, and the reason the data are so scanty here, is this is what happens with a rapid development program. They tried to treat all outpatients, right? And most of them ended up not getting into the hospital. They did shorten symptoms for people, though, statistically, right? But you have to ask for heroic intervention, like an IV infusion of infectious people, if the juice is worth the squeeze. So decreasing hospitalizations is very important, I think.
Especially right now when many of our hospitals are full. It's extremely important. Another quick question, what is the path for EUA to full approval? Can you give us some insight?
Well, yes, it's different, and people need to wrap their minds around it differently for vaccines versus a therapeutic. These therapeutics are not at the stage where we have all the data that we might need. But if you think back to remdesivir, it had a full efficacy trial plus a couple other efficacy trials that were not quite as robust. And it took a while, all that got together, and eventually it was approved by the FDA for an indication. These antibodies have, they don't have enough data, and also they're biologics, so the manufacturing has to be stabilized. These were made very quickly and scaled up to commercial scale, and so there are a lot of things that will have to be attended to. So it might be 5 or 6 months before these might be approved, were they to be approved.
Great. 2 quick questions before we transition. One is from Michael Miskell. Can monoclonal antibodies be used for patients with renal issues?
Yeah, they're not excreted by the kidney, so that's perfectly fine. I mean, I think you have to, of course, think about volume issues and so forth at some point, but they are not renally excreted drugs.
Great. Another practical question from Ellen Wilmore. Are patients who are physically in the hospital but are under observation and not admitted eligible?
Yes, this is John. I'd be happy to take that one.
Thanks, John.
And I answered that in the chat, and the answer is yes. Mm-hmm. Someone who is under observation is not an inpatient, and that's reimbursable. And we actually think that model, which might be a separate part of the ER or a separate wing of the hospital, is an excellent model for this.
Great. Thank you, John.
Right.
And thank you. Go ahead, Jen.
It's just, we don't want people who are too sick getting this because, the Regeneron trial that is ongoing in inpatients, they stopped the sickest or they've paused for the sickest people, and they're continuing for the less sick. And we stopped the Lilly product in Active 3 for futility in the inpatient study. So we don't know what's going on there, but and the line between who is admitted and who isn't admitted is admittedly a fine one. So, people who are getting on oxygen and doing all these things, we don't think should be people who would be eligible.
Great, understood. With that, thank you, Janet. I'm going to hand the baton to my colleague, Christian Ramers. Christian.
Great, thanks, Bruce. Good morning, good afternoon, everybody. We're going to next move to a polling question just to see what's going on out there before we move to our case study, and then hopefully plenty of time for Q&A. So Amanda, could we please bring up the polling question? Great, so I'll just read this out loud and please be quick with your answers so we can move forward. The question is, has your healthcare facility or system infused any patients with COVID-19 monoclonal antibodies? And I think we're relaunching it so everybody can have a chance to answer there. There we go. We've got nearly 500 of you watching, so please jump in and vote. Maybe a couple more seconds just while I talk about what's going to happen next. So, you know, the reason to do this webinar is to really share best practices and show people around the country what's going on the ground. And we're really happy to have a case study in rural Kentucky where we're going to hear how that's been done in one particular setting. So maybe let's close the poll and broadcast those results. Great. So about 23% have, 41% have not. And then some people don't know or are just very curious about it. So great. Thank you, Amanda. Okay, it's my pleasure to introduce Joan Haltom to take the next 10 minutes or so to go through the experience in rural Kentucky. Dr. Haltom is a pharmacist and has been a pharmacy director for 30 years with a bachelor's and doctoral degree in pharmacy from the University of Kentucky. She's past president and fellow of the Kentucky Society of Health System Pharmacists and currently a House of Delegates member for both KSHP and the American Society of Health System Pharmacists. And she's going to tell us about the experience in rural Kentucky implementing monoclonal antibodies.
Great. Thank you, Christian, for having me today. So I would like to just share our story because this is a very important project for many hospitals who are big or small across the country as we face record numbers of patients, both in our ERs and in our institutions. So Ephraim McDowell is a small rural system. It's independent. It consists of the 222-bed medical center in Danville, Kentucky, and 2 critical access hospitals to the counties north and south of us. We have about 30 rural health clinics and specialty clinics that service 6-county area of about 119,000 residents. This is the map. You can see we are about an hour to an hour and a half to a major medical academic center. And so we do serve as a resource for this central Kentucky area, which is mostly rural. This is a snapshot of Kentucky right now, and it probably looks like many of your states. Kentucky has had a total of 43,754 total cases. Almost all the counties are in the red zone, which means 25 plus per 100K population. In our service area, all counties are red zones. We've had about 5,000 total cases, 56 deaths, and we average about 150 new cases per day. So we started when the EUA came out for bamlanivimab to look and see how we could make this happen for our patients that, again, were positive, but really not sick enough at that point to be admitted. We started on 11/13 with a Kentucky Hospital Association call regarding the process for signing up for allocation from HHS. We submitted paperwork the next day. We worked with AmeriSource on a huddle call on the 18th and got that set up for auto ship. And then the 11/18 date was the first time that our team, a multidisciplinary team, came together to brainstorm how we would make this happen. And we had some big barriers to overcome. On the 23rd, we had a follow-up meeting. And of course, that was the week of Thanksgiving. So we got our order sets approved. We had our initial call with our ID physician to our clinic providers about what the process would be and the criteria. And then we had our first patient treated in our ADU area, which is an adult area connected for observation or outpatients adjacent to our ER setting on December 2nd. So our journey, like I said, the biggest things we had to address were drug procurement, which pharmacy did most of that work. The order set and referral process, again, our clinical pharmacist developed an order set based on the criteria. And then we worked with our ID physician to build in what that referral process would look like from outside practitioners. The space and staffing was one of the largest barriers in that we are really stretched thin in terms of nurses being able to staff. If we created a new unit, who would staff it? So that was a big question. And then space, of course, these are COVID positive patients. And so we were really concerned about commingling and throughput of the patients. We didn't want them coming and trying to enter the hospital and mixing with patients that we didn't know if they were positive or negative, or that they were there for non-COVID related illnesses. The drug distribution, storage, and administration concerns, again, were handled mainly by pharmacy, as were the setup for emergency medications in this area. So we looked at what equipment we would need for if we created a new unit, including infusion chairs instead of beds. And then the registration process, again, with COVID positive patients, we didn't want them going to our main registration area. And then patient entry and rooming process for our new process, medical record documentation, of course, the patient education and consent, and then last but not least, the charge process. So we developed an order set that built the criteria and a flow algorithm right into the order set, so that as we sent this out to the clinics, it was very straightforward. We asked them to indicate how the patient met criteria. And then this part that's indicated with the blue, the clinic provider then would consult our ID physician, who kind of served as a gatekeeper and documented the date and time that they had consulted and agreed that the patient met criteria or did not meet criteria. And we felt that this was an important step to try to make sure that our allocation and supply met demand, and that we had some sort of prioritization of patients based on criteria. We had the order set along with the hypersensitivity orders and the flushes to make sure that the total dose was infused on the order set. So the patient flow plan, again, the clinic positive patient would be referred. They would consult with the ID physician, who would then provide the order set. The clinic provider would complete the order set and document the approval. And then that was faxed to our recovery 3 area. So we pulled in our OR team to really work on this throughput process, because that was our existing mechanism for doing outpatient infusions here at the medical center. And then any ER COVID-19 positive patient also was going to be referred from the ED provider to the Recovery 3 unit for the same process, mainly not to create a backlog and tie up our ED community, our ED throughput and beds, which is already overrun. The Recovery 3 team then would contact the patient to schedule the infusion and instruct them on how to report for the appointment. They would pre-register the patient account, provide a daily schedule and orders to central pharmacy by 2 p.m. the day prior, and then they would provide the patient order, H&P, and charge sheet to the provider who was going to be administering the drug in the ADU unit. So upon arrival, we did have our provider have a special phone. The patients were instructed to park in our ED parking lot, but not enter through the main ED entrance. Instead, there was a separate outside entrance for that area. So they would call, the provider would actually meet them and allow them entry and room the patient. And then they would provide registration. Registration then would register the patient, deliver the armband and consent and charge sheet to the zip wall area. And then the provider would educate, obtain consent, and return the paperwork after the patient left. So this is signage was important for us to, again, try to guide our patients that only this door is only used for those patients. So the provider would come here and let the patients enter through this separate entrance. And then once in, they would enter this area where that the patients would actually receive the medication. The provider, again, we actually redeployed or reassigned one of our clinic nurse practitioners to come back to Ephraim, the medical center, and provide this service Monday through Friday for us. So, you know, that was one of our biggest barriers. They then would administer the infusion and flush the line to make sure that, again, the full dose was administered through the port. And then they would observe the patient for another hour post-infusion. They would be ready to administer any emergency medications if the patient displayed those symptoms of an allergic reaction. They would remove IV access at completion and provide discharge instructions to the patient. And then documentation, of course, of the drugs. So this is just a picture of how we set up a single room. We have a throughput of 3 patients with staggered start times 30 minutes apart. So one provider can bring patients in, get them started, and still be monitoring the other patients. And we did a schedule with 2 blocks, a morning block and an afternoon block. So we have a capacity for 6 patients a day. At the completion of that, then the patient would be discharged back home. Again, their caregivers are waiting in the car because we were not at this time allowing visitors. So they would pick them up outside the ER ADU entrance and with instructions to remain under quarantine. And then follow-up was with their primary care physician who referred them, or to the ID physician if they did not have primary care or if they'd been referred by the ED physician. So pharmacy, again, had an integral role here in developing both the protocols and drug procurement and the process. You know, necessity drives invention. So this has been the year for that, I think, for our institutions. So these are some of the challenges that we had, as I've mentioned, many of them related to space and block and throughput and how that we could really keep those patients segregated and keep the rest of our patients safely away. And then, of course, the demand and referrals, that prioritization. We're fortunate to have an ID physician. We only have had that person in place for about a year. So I can't imagine going through this pandemic without that resource. So that's a big advantage that we've had that some hospitals may not have. And then, of course, the allocation and limited supply. We did, before we got our AD unit operational, we had an ED physician that had an appropriate patient and wanted to give it in the ED, and it was at night, and we did allow them to give it. But that led to that prioritization and the ID enrollment to approve and to funnel the ED referrals through the same process so that we could really prioritize patients based on supply. So in summary, it took us about 2 weeks. Again, we're kind of nimble because we're small, and that's an advantage that small hospitals have, to be able to make decisions, pull teams together, and work out processes. But it took about 2 weeks to get the service off the ground. To date, we have administered to 10 of our 11 patients scheduled. We did have one patient that in the day that it took to schedule them and get them back, they had declined significantly, and they were very unsteady on their feet and did not feel like they could sit up in the infusion chair. So we did defer treatment for that patient. We've had no infusion reactions reported at this time. The biggest side effects that we've heard from our patients are more GI related after infusion. Are there any questions?
Thank you so much, Joan. I think we'll have time just for maybe 1 or 2 questions. And the first I'll start with, which is that I'm wondering how you balance the supply with the demand. You said 10 of 11 have been infused, but did you have many more patients that might have met criteria?
No, we haven't. That's actually one of our, biggest concerns, is that we would have more demand than supply initially. And again, this is very early, we're week 2 of this. But our ID physician said he's only had maybe 3 referrals that have not met criteria. And to get the word out, he has a weekly call with our clinic physicians, and physicians in the community are invited to be on those calls. So I think it's about getting the word out that we have it and we have a mechanism for safe administration, because I don't think that people are aware of where that they can refer patients to have this drug safely administered.
Are you doing some type of information campaign or getting the word out so that you can reach the harder to reach spots?
Right. So our ID physician is having weekly calls that are open to the physicians and anyone who wants to join that call to find out about what we're doing in our system. I know we have had some referrals from outside our 6 county areas based on connections. So we might have employees that work outside of that live outside of our 6 counties that might be driving an hour to work here, but they have neighbors, friends, or that they've referred. And so we have had some outside physicians reach out to us because they've been told that we have it, and the hospital closest to them may not have it.
All right, great. Thank you so much for sharing your experience. I'm going to move us along and get our panel involved for the questions. And please keep the questions coming in through the Q&A. I see over 30 have come in, so that's great. It's my pleasure to introduce the panel very quickly. You should have their more extensive bio available by email, but I'm just going to do a brief one here. So we're happy to have Priya Nori. Priya is an ID physician and alumna of Johns Hopkins and Albert Einstein College of Medicine with a focus on medical education, and works at Montefiore Medical Center and helped stand up a program there. Also with her is Carol Sheridan, Assistant Director of Infection Control at Montefiore, also involved very heavily in the initial wave of SARS-CoV-2 and is helping stand up the workflows for administering monoclonals right now. We have Carl Steinberg. Carl's a geriatrician and has been a nursing home, hospice, and home health agency medical director in my neck of the woods in San Diego since 1995. He's president-elect of AMDA, which is a little confusing, American Medical Directors Association, also known as the Society for Post-Acute and Long-Term Care Medicine. And just a quick plug, he's actually organizing a separate meeting, which will start on Thursday, dedicated to administration of monoclonals in long-term care settings. We have Ed Michelson, who is the chair of the Department of Medicine at Texas Tech University in El Paso. And last month, he helped establish and oversee an infusion center for administering monoclonals in an alternate care site in El Paso. If you've been following the news, El Paso and Juarez are a very big hotspot right now, and also has an additional diagnostic and therapeutic trials for COVID-19. And then finally, we have Carol Cunningham, who's an ED physician and the state medical director for EMS in Ohio, and a frequent panelist on other COVID-19 echoes, and hoping that Joan and Janet can also stay for our discussion as well. So let me get started right away. And again, please keep the questions coming. I want to start with a question that's probably on everybody's mind, and it's regarding allocation and distribution. So I'm wondering if John or Janet can jump in on here. The question is, how is information going to be shared with healthcare providers, including primary care folks, regarding the availability and access to monoclonals?
Thanks. This is John. I'd be happy to take that one. So actually, today being Wednesday is the day that we do our allocations for this week, and we post them at phe.gov. So that's the ASPR website. So www.phe.gov, and it's got information on previous allocations, goes back to remdesivir. But so everyone knows, we're currently in the 5th week of bamlanivimab allocations, and just this morning, we are preparing 44,380 patient courses, and that's in addition to 215,540 that we allocated in the previous 4 weeks. And then in total for casirivimab and imdevimab, it's been just a little shy of 80,000. So those are the numbers. But the immediate contact should be the State Department of Health. And we are working very actively on public-facing, web-based solutions to seeing where a product is located. Thank you.
Thanks, John. And maybe John or Janet or David can jump in. Is there a sense of a forecast of where we're headed in the next 1 to 2 months? Does the supply look like it's adequate?
Well, the United States government has procured 650,000 courses of bamlanivimab, and that's 300,000 of the combined product from Regeneron. And the question of whether it's sufficient is really the active one, of course, and that's been hard to know because for 2 reasons. First of all, as we've all seen and been humbled by in the last 8 months, anyone who thinks that he or she can predict exactly where the pandemic is going has been humbled in the last few months. So it's hard to predict the future. But secondly, as we've been discussing today, there are challenges to their administration. Now, there are solutions to those challenges, don't get me wrong, but we're very interested in reaching out and hearing how people are solving those challenges so we can have a better idea of what the real availability of the US system is to deliver them.
Great, thanks for that. And I want to ask a question about nursing home administration, maybe bring Carl into the discussion here. Are you aware of nursing home or long-term care centers being able to administer this in practice?
Yes, it's just kind of getting underway right now, but there are some areas that have been able to obtain this. The initial allotment went out to hospitals, and so there's just a lot of bureaucracy involved with trying to get it from a hospital into a SNF. places that have on-site, like hospitals that have on-site SNFs, obviously can do it easily. I think over the next several weeks, we plan to see more of it being allocated to skilled nursing facilities, starting as a pilot through Operation Warp Speed. But I think it's an ideal setting, and we appreciate that our patient population is particularly high risk, and they're already set up to give it there.
Great, thanks, Carl. And then David, I see you just came on video. A question I was going to pitch to you is about just the emphasis or the focus on hospitals initially, and is there a little bit of a shift over towards different settings?
Yes, I'm part of Dr. Red's team, and so we are looking at different, what we're calling micro pilots, to test in different settings that are high risk and vulnerable. Carl mentioned the effort with long-term care and home infusion pilot. We're also looking at areas like federally qualified health centers and state and county correctional facilities, because those are areas that if we can get product to them faster in, supplemental to the state allocations, that's going to be really helpful for our country.
Great, thank you, David. I want to move into some more clinical issues. And Janet, I'm not sure if you're still on yet, but a quick question for you regarding timing of administration. I think you did mention that some of the different trials had sort of a really quick 3 days from diagnosis. Some had a 10-day for diagnosis. Could you just detail quickly in the EUA how soon these products need to be given after diagnosis?
The goal is to do them as soon after diagnosis as possible. And I think like something, as long as they're still out of the hospital, right? They are still eligible, right? If they haven't developed symptoms. But the real goal is to get, these will work better. Everyone agrees the earlier they go into the people. And probably it's not, since we're in short supply, somebody who is recovering and had a COVID test 5 days ago and is recovering is not a really good candidate for this. So I really think rather than focusing on a time limit, it's really about getting it into them as quickly as they can.
Great, thanks. And so we get into the practical issues of now testing and how quickly testing can get done. And Ed, I wanted to get your thoughts on this question from Joseph Widener, understanding whether antigen testing would be enough for a high-risk patient to receive the monoclonal, or do you need to wait for that PCR, which may take several more days? What have you been doing in Texas?
Yep. So an antigen test is sufficient if it's positive. As part of rolling out the Binax, Abbott Binax card test, although it's waived, our institution thought that we had to validate it. So we've done an internal validation and we've come up with some actual false negatives. So what I would say is if the patient's symptomatic, they look like they have COVID and the antigen test is negative, I wouldn't rely on that. But if it's positive, I think that's good enough to go.
Yeah, it's good advice.
Thanks. And let's get an opinion from New York. Priya and Carol, if I could get your idea. How about, I imagine New York City, or New York being with a large population, you probably have more patients than drug, right? And so how are you working on sort of prioritizing who gets the monoclonal?
Sure. Yeah, I would love to share. So we are in a kind of a ramp up phase right now. New York is steadily increasing, and we are approaching numbers that we had back in maybe May as our spring curve was coming down. However, because we are, not only are we in New York City, but we're in the Bronx, which is for the most part a federally underserved area. Most of the residents are communities of color, and we had the highest death rates back in the spring. So in addition to the guidance from the FDA, from the EUA, the document, we are also taking into consideration certain other things, like, are you an essential worker? Are you from or do you have the ability to self-isolate away from your family members? Do you take the subway to work? We try to think about as many social determinants of health as we can when making our decisions as to eligibility. We are still admittedly very early in this process, and the individuals we've infused so far have, for the most part, been from communities of color, and are basically essential workers. So that's kind of our flavor. And then going back to the long-term care, we have several long-term care facilities that are very close, within a few miles of our hospital. We don't own them, but we partner with them. And so we've formed an agreement in which we constitute, prepare the medication, our ID physicians help screen, and then we have regularly scheduled pickups for the local skilled nursing facilities to come to our central pharmacy and get the drug. And then our ID physicians basically do serial televisits with the residents to make sure that they're out of the woods.
Thank you. And Carol, are there any practical hitches that you've seen? It looks like some people are asking about what kind of testing needs to be done before getting people in.
So I can speak to, and I'll let Dr. Nori follow this up, but in our institution, we made a decision to quickly ramp this up through our ED, since that's the portal of entry, if you will, for most of our patients. We do a rapid PCR on all patients who come in who look like a COVID patient. And so we made the decision that rather than try to move the patients out of that area, we would start in the ED. So that is where we started. We've used our oncology nursing group, who has the most expertise in the hospital, along with our PharmDs, to develop a interdisciplinary education program, and have started doing that. And yesterday, Priya, we were successful in getting 2 patients treated. But we are actively looking, as our colleagues in Kentucky talked about, is another ambulatory site, because we don't want to create a bottleneck if the number of cases continue to increase. And the emergency room staff recognize that. That's why they've embraced this, because we've sort of sold the fact that if we can get these monoclonals into patients early, we can get them out of the hospital, and we won't create a bottleneck up in the ICUs or the med-surg units.
If I can
I have a
add
question.
to that,
Oops.
I'm sorry, if I can just add to Carol's comment, we did have a provider that did a Facebook posting that Ephraim was going to have this drug, and if you were positive, you could get this. And we were bombarded with calls from patients. So just know that that's a real factor. And so that's one of the reasons why we felt like that we had to have a gatekeeper to kind of filter those out. But they were calling the pharmacy, they were calling, I mean, anyone they knew, like, how
Right.
can we get this? Where do we go? They were calling our clinics, expecting just to be able to go to the clinic and get it. So just be prepared.
Yeah, that's what I was going to ask, actually. This is Janet Woodcock. It's right now, most practitioners, I think, don't know where to get it. Most practitioners out in the community. But what I wanted to ask you, Joan, and others, are you reluctant to let it be known you have the antibody, because you will be deluged?
Well, like I said, at first we felt like that we would make our clinic physicians and providers in our community, even if they weren't affiliated with a hospital, aware that it was available in our community, because this is a community problem. And so for us, that's how we started down that path. And like I said, we did get referrals from outside of our service area that, again, if we had openings in the schedule and they met criteria, we felt like that, yes, we would do that. We have the drug, we want to use it and treat people. But I think our fears of, running out of that allocation were great on the front end. And like I said, there's a little bit slower uptake in the administration than we expected. And I think a lot of that is trying to get the word out. So we almost need like the Vax Finder process to show where that patients or providers can refer to get the MABs.
Right.
Thank you, Joan. If I could, I think John had a comment about allocation he wanted to get in there real quick.
Yes, I just wanted to say that well, 2 things. Joan's great presentation emphasized 2 things that are emerging best practices. First is that they're using auto shipping or auto confirming. What that means is that whatever that ahead of time the state and the recipient place say to the distributor, we'll take what you offer. And it makes things like from this morning's allocation, places that have auto shipped their product will ship this afternoon for delivery tomorrow. and they also integrated their EMR. And I want to point out, Kentucky's been out in front of this for the whole pandemic, including with remdesivir. So my hat's off to you. But in regards to local supply, please do email if you're having local supply problems. This is not a request-based system. However, in the face of spotty uptake around the country, we are very much willing to listen to places that are being successful using it, and if they're getting low. Thank you.
Thank you, John. We just have a couple minutes left, and I want to bring a question to Carol and then Carl about where this is allowed to be administered. So Carol, in terms of emergency rooms, urgent care centers, are there any restrictions on where this product can be given? Carol Cunningham, that is.
It varies by state. I can tell you in the state of Ohio, we have made avenues where paramedics who are serving in mobile integrated healthcare systems can go out in partnership with the physician oversight and administer in the home. This is really important for our rural areas. We have one county in Ohio that doesn't even have a hospital. Going back to what Joan said, I do think there's a gap in community education. Because everyone's so Google savvy, they hear that this is what you can have, the drug you can get when you're COVID positive. We're starting to see a lot of people, particularly if they don't have a primary care physician, call 911 for transport to the emergency department, thinking that they can just get it there, like you can get a tablet of Tylenol. So I do think we need to work a bit on that and educate the community on how it's a selective process. Thank you.
Thanks, Carol. I think we just have time for one or two more questions. Over to you, Carl. A question about administration in long-term care facilities with the staffing challenges and different levels of nursing expertise.
Yeah, I'd say virtually all nursing homes or a great majority of nursing homes have the ability to give it. They've got somebody on staff who can, administer IVs. But several attendees have brought up the issue that nursing homes may already be short-staffed or working, especially when there's an outbreak. And I wish I had a simple solution to that. There's talk of home infusion services actually coming in and giving them on site. There's also other ways of getting outside staff to potentially come in, hang it, and monitor the resident. But if anyone has a great answer to that, I'd love to hear it.
Great, and another pitch for Thursday's long-term care Echo to talk more about this. I think I have time for one more question that I'm going to bring Janet back in, and just to settle the issue of vaccines. We're getting our first shipment of Pfizer vaccine in San Diego next week. People have questions about whether a vaccine can be safely administered after infusion of monoclonals.
Yep, it hasn't really been tested. There is not a theoretical reason because these are human monoclonals, okay? It's going to be a very similar situation to where people already have antibodies themselves. If I were just doing caution, I would probably wait. The half-life of human IgG is about, 3 weeks, 4 weeks. I might, if I had just had COVID actually, or I'd just gotten a monoclonal, and so I had high antibodies, I might wait a while before I got the vaccine, just put myself a little bit later in the line, because you probably are protected at that point for quite a while, right? However, there's no mechanistic reason. The concern is more for people who get it prophylactically, as I said, that especially long-lasting antibody, which these two are not, that it would suppress the immune response. But these people have all been infected. So they've seen the virus already. They've seen those antigens before. So everybody who's gotten a monoclonal now is getting it in, except if they were in a trial, is getting it in a therapeutic situation.
Thanks, Janet. And just from a clinical perspective, I agree. I would not think a person who just had COVID and got passive immunity needs to be first in line because they probably have pretty good protection. Priya, one other comment quickly?
Yes, so the CDC, not addressing MABs, but they're saying in their FAQs, they're saying 90 days between infection and receipt of vaccine. They haven't addressed how the MABs changed that timeline, but essentially our recommendation can be, you have to wait, unfortunately, about 90 days before you're a candidate for the vaccine. if you've had recent infection.
Sure. And if I could interject, a lot of these people who are in the hospital have gotten convalescent plasma as well. So they would have gotten a polyclonal antibody too. So it's probably prudent. They aren't at high risk of recurrence, and it's probably prudent to wait a little while to vaccinate them.
Great. Thanks, everyone. Very rich discussion. Obviously, we have many more questions to answer, and I hope you join us next week and then through January to keep the discussion going. I'm going to pitch it back to John to close out the session.
Thanks, everybody. This was really a wonderful discussion, and I really look forward to the next echoes. I just want to say that we want to keep moving this forward together in a spirit of transparency, shared decision-making. We literally are in this together. So let's keep it moving forward in that spirit. So it's really been a fabulous session. Thank you very much.
Thanks, everyone. Stay safe. Take care.
Well,